Mammography. So we're going to talk today about image quality metrics and how to optimize them for mammography. So image quality today. Next week, dose in mammography. Now you're going to hear me say dose a couple of times, I'm sure, because as we all know, dose and image quality are linked. Excuse me. So mammography. Why do we even what's so special about mammography? Excuse me, got the hiccups all of a sudden. It is one of three imaging techniques that we use as a screening tool. Obviously, dental is the other one. We go in for get our dental x-rays every year. And more recently, we started doing CT scan screening for lung cancer. But mammography and dental are the most common, and pretty much everyone gets a, especially women after a certain age. Now, when we look at the reason why we screen for mammography is breast cancer, of course. And so I looked up the statistics. These numbers come from the WHO, the World Health Organization. Among Thai women, breast cancer is the #1 killer. There are roughly 22,000 new cases a year in Thailand and approximately 8,300 deaths a year. And so when you look at a breakdown, so this is talking only women, and this is 2020, so this is really recent data, you can see the biggest chunk of cancers for women is breast. Now, why is that a good thing? Because breast cancer is largely curable if we can detect it early. Now, you could say that about any cancer. If we can detect most cancers early, we can almost always cure it. But breast cancer, if we can catch it early, we can cure it. And that is why we screen with mammography, excuse me. Okay, the problem is, what are we looking for in mammography? There are some very specific things we need to see. Therefore, these are the image quality metrics that we need to optimize. The first is spatial resolution. We need to be able to see microcalcifications, which are usually early markers of disease that will eventually turn into a palpable disease or a mass. So microcalcs are very important, and these things are teeny. We need to be able to visualize something that's about 0.15 millimeters. 150 microns is tiny. We also need to be able to see low contrast noise resolution. We need to be able to visualize the tumor itself. The problem is the tumor is made of the same material, the glandular material of obviously of the ducts, the glandular, and then all of the supporting structures, the vessels and the ligaments and all that stuff. The difference in contrast between the tumor itself and what we see in the breast they're very, very low contrast. In other words, they're very similar. So we need to be able to visualize the tumor, and we need to visualize the architectural distortions that come with just looking at the breast structure itself. We need to be able to do this in a variety of ways, both for 2D full field digital mammography, so 2D, craniocaudal and medial lateral obliques, so MLOs, and with our newer technology within the last 5 to 10 years, tomosynthesis, or kind of the quote unquote 3-dimensional breast imaging. So the ultimate goal of screening mammography is to visualize something before it's palpable. Because once a woman can start to recognize, and I know there are other signs from, like nipple discharge, bleeding, and all that other stuff. So I know there are other things besides just a simple palpable mass, but the point here is once it gets to palpable, it's a pretty good size mass we're dealing with. So we need to see something small in a radiograph, in a mammogram. And all of these things we've talked about are actually, and that's the problem, is they're conflicting. We need to see teeny tiny microcalcs, but we also need to see something that, as you can see here, that is of low contrast, even though in more diffuse, less edge enhanced objects, be they architectural distortions or a mass itself. And so because of this inherent conflict of needing to see the microcalcs, this high resolution, and the low contrast mass and architectural distortions, uh, we we have to be able to balance what we can do with good MA and good resolution. So we're going to talk about that. So that was just trying to set up the need to discuss this. So let's start talking a little bit about the low contrast visualization. So in the US, they have the ACR, are one of our societies for radiology. They've worked on establishing what are called the BIRADS, or they basically give you kind of um, a way to define how you visualize the image. And so, for example, diagnostically speaking, you can go from like a BIRAD 1, which is mostly fatty, to a 4, which is glandular fibrotic. Obviously, you can go like 5, 6, and I think up to 8. I can definitely know up to 6. But the point is you have you have the breast that doesn't always, one female breast to the next is different, and then one woman's breast over time is different. And so we have these different classifications. We call them here in the US BIRADS. I don't know if you use the same ones in Thailand or something similar. But the issue here is when you look at basically the material that we're imaging, which is glandular tissue, you have, of course, the ligaments and the vessels, which are going to be relatively high attenuating. That's why they appear white in the image. And then predominantly fat, which is going to appear more gray. Now, I know, of course, in the MLOs, you're going to get some muscle up here. But for the most part, what we're dealing with here are these fats and these glandular tissues. Now, you can distinguish the difference between fat and glandular tissue very easy at any stage, any BIRAD ranking of any of these breasts. And that's because you look at the attenuation profile, fat attenuates less radiation versus glandular, hence glandular is whiter. Now, that is true for basically all energies that we're imaging with. Down here is the Mammo range, up here is the CT range, and anything in between, basically from about 50-ish over here, well, 40-ish over here, this is your DR or X-ray. So fat can always be visualized in both of these, in all energy ranges. That's not an issue. But when you look at glandular tissue, as an example, compared to infiltrating ductal carcinoma, the mass that you got to somehow find in all of this, down here in the CT range and in the general X-ray range, there is basically no contrast difference. They attenuate photons the same. The only time that these two start to separate are down at the really low energies. That is why we must image with low kV in mammography, is because of this very, very subtle difference in glandular tissue versus the actual mass or disease. So we'll talk a little bit about imaging down here in a moment when we actually start talking about the beam spectrum. So let's talk now about the high spatial resolution. So obviously we're doing this primarily to see the microcalcifications. This requires high X-ray energies. So right here is the conflict, and it also requires a very, very small focal spot, which only allows for low MA. So if you have low MA and high kV, that's actually the complete opposite of what you want with contrast. In this case, you want low kV and high MA, so you have no noise. And so what we need to do is we need to balance this, because we cannot have high dose in mammography if it's going to be a screening tool. Because if you're going to ask a woman to come in, but she turns 40 every year, or maybe every other year if her risk factors are real low up to a certain point, then you can't be exposing her breast tissue to very high doses. So looking at the machine, let's talk about the various different functions or factors in this machine that we need to optimize to get good spatial resolution and good low contrast, but do it in a way to have low dose. So completely conflicting, as I hope I just established. We're going to talk about the X-ray tube and the filters, compression paddle, and the grid. So the things here listed in blue are really what we're going to focus on today. Of course, everything else is part of this. Now, you see here, I didn't actually highlight the AEC or the machine, the part of the, the ion chamber down here that controls the amount of photons that come out. Obviously, that's the most basic thing. If that system isn't working, you're not going to get radiation out and you're not going to get the right radiation. So what I really want to do is talk about some of the more subtle things that I know you guys have all got your AEC systems up. I mean, that's just a standard process. Every mammogram has an AEC. Now, you may use a fixed technique, so therefore you have your charts. However you approach it, you've set up the right MA and KV combinations. That I'm using as my basic assumption for this talk. What I think will be interesting is when you look at all of these options to optimize, the compression paddle, I think, is the one that gives us the biggest variability to image quality. So we'll talk a bit about that one. So starting in the X-ray tube, starting at the top down, the cathode. This is where all the magic happens to begin with. Here you can see the cathode with the large filament. So this is the large focal spot, and this is the small filament with the small focal spot. Typically speaking, we have two focal spots in mammography, and we need this because we're going to image the breast in two locations. One, in what we call contact. So the breast is on the contact images. The breast is down here directly in contact with the detector Bucky system. So the grid, the detector, breast is down here. In a moment, we'll talk about magnification, which I know are all aware of. You'll place a stand here and actually image the breast higher up, so closer to the X-ray tube. When we image under conditions of contact, therefore the source to the image source to the breast tissue is farther away, we have to use higher MA. Because remember, inverse law says as photons go from the source down to the detector, it changes by 1 over the distance squared. So you're reducing the amount of photons coming out as a function of distance. The problem with that is if we use really high MA, we have to use large focal spots. In fact, I'll just hop down to here. Typically in X-ray, so DRCR, we use a small focal spot of 0.6 and a large focal spot of 1.2. The reason for this is because we have to use lots of MA to penetrate large parts of our body. So chest, abdomen, pelvis, obviously. And then if you're doing, chest radiographs or you're doing a scoli, the X-ray tube and the patient are very far apart compared to maybe doing imaging on the body, on the table. So you need high MA to do this. You cannot do a lot of a high MA on a small focal spot. You'll just burn this filament out, it'll break. So in mammography, to keep the MA low so that we can use a very, very small focal spot, we keep the MA low so we can use a very small focal spot. So why do we use very small focal spots? It's so that we can get good resolution. The smaller the focal spot, the smaller the object we can see. Now, the problem with that is we still need to penetrate the breast tissue. Now, we're going to talk about how we're going to make that smaller by compression, but we still have to penetrate a certain amount of breast tissue. So therefore, we need enough MA, or enough photons to get through. If we are limited on how high we can turn the MA, when you look at the equation, MA times time, so the mass, the only thing you can do is leave the machine on longer. So mammography, of all the imaging modalities, is probably the one that is most susceptible to patient motion. And that's because with the large focal spot, so breast in contact to the detector, we're imaging, we're turning on the machine for probably 1 to 2 seconds. So if the lady just moves just a little bit or whatever happens, you can see here, this image has motion blur in it. So everything has just got a blurry look to it, no crisp edges. Same patient, same view. They simply just redid the image and you can see how much more crisp it is. All these little microcalcs, you can visualize some of the ligaments, the stranding, or the vessels, the vasculature, you can see it. Obviously, the glandular tissue is a little more crisp. And the other thing is when we go to magnification view, remember magnification view has very low MA output. We typically only do about 25 MA, whereas contact is about 100 MA. And because of that, for mag views, we almost always have to image for up to 3 seconds. So we have a lot more potential for motion in a magnification view. So looking at the orientation of the X-ray tube, the focal spot itself is set at an angle to the detector. And we do this is called the line focus principle. We talked already about this in X-ray. You remember the heel effect, all of that stuff. We've already talked about this when we talked about a couple of weeks ago. But the thing about this is it gives us the ability to have a larger focal. We have actually I meant to say, well, basically what I'm trying to say here is you can have a relatively large focal spot here, but you have a smaller effective focal spot down here. Let me try to say that better. Because of the angle of the target, the amount, the electrons as they strike at that focal spot gets actually spread out a little bit. So heat-wise on the tube, the heat gets distributed more, so you can use a little bit more MA. But because of the way it comes down and it diverges, it actually projects a smaller focal spot on the detector than it is on the target or the anode. I go into a lot more detail several slides ago or several talks ago, so please go back to that. But the point of this line focus principle, it gives us the opportunity to give us really good spatial resolution for mammography, and it's mostly based on the nipple side. So resolution is best at the anode side, which corresponds to the nipple side for imaging. You really won't notice this better resolution difference in contact imaging, but when you're magged up, and if you're, let's say you're magging and you're actually doing more of you're imaging more towards the nipple side or the anterior side, then what's happening here is you will actually notice the spatial resolution is a little bit better there. Okay, so the other thing here is the tube is tilted so that we can have a larger field of view. If this tube was flat, then your field of view would be limited. You wouldn't be able to get all the way out to 25 to 30 centimeters. And what we want to do is we want to image as much of the breast as possible. So for small breasts, that's not an issue. But for relatively large breasts, then if they don't fit on the field of view, of course, you'd have to do 2 images. So you're just doubling the dose of the breast. So having a larger field of view is good because you can get all the anatomy in one shot. But it's also especially important when you're doing the medial lateral oblique or the MLO view. So now, as you're imaging this way, you're going to get up into the axilla, and you need to be able to image up here to visualize, the axilla to get some of the lymph nodes. But the upper outer quadrant of the breast, I know you all know this, but the upper outer quadrant of the breast is where we find a lot of breast cancer. And so getting a larger field of view, especially in the medial lateral oblique view, is very, very important. So you can image what is probably one of the more important or sensitive areas of the tissue. So let's look at the concept of how is the resolution limited? So in contact mammo, which is majority of what we do in full field digital mammography, the resolution is limited by the focal spot size. So when you have a 0.3 millimeter focal spot, you will just have a limit to what the smallest object you can see in the detector. Now you bring the breast up in a mag mode, because remember, you get magnification. The farther away from the detector you get, the bigger the object appears in the reconstructed image. So as you do that, as you put the breast higher, you're geometrically magnifying the image. Now the resolution limitation is not the focal spot anymore, it's the detector. So this is where you need to have a really good, high quality detector, really finely spaced dexels or DELs, the digital pixel values. Okay, so that's the cathode. Let's move over to the target, the anode. Historically, these were made out of one of 2 target materials. First would be molybdenum, and the other may have been rhodium. So we had your moly and your rhodium as your 2 options for targets. This was predominantly done during the screen film era. There is one vendor still on the market, GE. It's probably not a surprise for those of you that know that. but there's one vendor on the market that still uses the Moly-Rowe targets toward the anode. There is a lot of benefits to this. The molybdenum have K-edge and the molybdenum and the rhodium have K-edge values in the energy range that we are using for mammography. So that gives us the opportunity to really focus our imaging to get really good monoenergetic photons in the area, in the range which we're doing our imaging in, so that we get good high contrast. This was very important, especially in the film era, because film, the contrast was based on your technique. If you overexposed or underexposed, you lost your technique. You lost your contrast, excuse me. In digital imaging, if you under or overexposed, as we talked about a couple weeks ago, you can actually manipulate the image. You can change the latitude on your post-processing, and you can actually recover most of that contrast. So you can make it look okay. And for that reason, most digital systems nowadays have moved to using a tungsten target or an anode. Tungsten, of course, has a much higher melting point, so you can use higher MA or MA on longer, so you have less potential for damage. But the problem with that is there are no K edges. There is a K edge for tungsten at 69.5 keV, so that's way outside of the range of mammography. We use that in radiography when we're imaging obviously up in this range. They do have L edge, which we'll talk about in a moment, but that's down in the 10 keV, and 10 keV is too low, and I'll explain in a second. But because of the digital systems, the dynamic range of the digital systems, we can actually get away with using tungsten a lot more. So tungsten gives us a larger bremsstrahlung spectrum. You can kind of see these spectrums here. These are all tungsten spectrums with different filters: rhodium, silver, aluminum. And that gives us the ability to image a good wide spectrum within that 10 to 30 keV. 20 is kind of the sweet spot. That's why you see these are all basically centered over the 20. I mentioned these L shells for tungsten. Anything less than 10 keV, and we'll talk about this next week in dose, when we talk dose optimization, all of this is just skin dose. A 10 keV photon will absorb on your skin. It will not penetrate. And so it will not go through the breast. So we want to get rid of all those. And in every case, tungsten can be paired with various different filters, such as rhodium or silver or aluminum, and it gets rid of all these L shells, and it gets rid of these high keV, these high energy photons up here that would decrease our contrast. So pretty much all scanners nowadays are moving towards tungsten. They are usually typically using a tungsten rhodium combination, although you can, like I said, say tungsten silver or tungsten aluminum. But when you look at, say, tungsten rhodium as a combination of target and filter, we are seeing glandular doses that have been reduced by about 50%. But the noise signal to noise ratio, the SNR, stays basically the same compared to our old film days when we use Moly-Moly, Moly-Rowe, or Row-Row. And then we'll talk about breast tomosynthesis a little bit later, but basically we need, because we're now doing a sweep, an arc, and imaging multiple different angles, the tube is on longer. We absolutely need a target such as tungsten that has a higher melting point so we have less damage. Okay, so real quickly, when you look at the Bremsstrahlung spectrum that we use this is a generic one that we use in mammography, everything that's real low, less than basically 15, is going to give you skin dose. We want to get rid of that. And everything above 20-ish, above 22, 23, all of that is basically going to cause you to lose contrast. So what we're going to try to do is we're going to try to image right here in the dead center. All of our systems will have a beryllium exit port. So all X-ray tubes, they're made with glass envelope, but the place where the photons come out, because the glass would absorb almost all of these low energy photons, they actually have to use a little beryllium window. And now beryllium will add a little bit of attenuation, but not a lot. It gets rid of the basically 5 and under keV. So we have to do some kind of anode paired with a filter. For those of you that still have film, film-based systems, well, then you're going to have a moly target. You're going to have one of two options. You're going to have a moly or a rho target, a molybdenum or a rhodium target. And that is because we want these K edge values, these characteristic X-rays. These really strong characteristic X-rays provide really good imaging that gives really good contrast. And that is the whole reason why we did that in film, as I already explained. Depending on the thickness of the breast, depends on the KV selection option you'd use with the moly target. And it depends if you would use a moly target with a moly filter. So it's if it's thin, fatty breast or a little bit thicker glandular breast. Now, if you use the moly target with a rho filter, you're doing this for the much denser breasts. And that's just because the rhodium, well, yeah, it's just because you're going to basically keep a little bit more of these higher energy photons to penetrate the thicker breast. So a moly-moly combination or a moly-rho combination will just really get rid of most of this right here. But if you did a moly-moly combination gets rid of this right here. A moly-rho leaves a little bit of that behind. So that you actually had to pay attention to the breast thickness back in the green film days. A rho-rho is the same thing. It's shifted a little bit more to the right, and we use these for real thick breasts. And we would never, ever, ever use a rho target with a moly filter, because if you had a moly filter on a rho target, it's going to get rid of the characteristic X-rays of the rho target. And that's just because the characteristic X-rays of molybdenum is lower than rhodium. And so we never, ever want to do that. So moly, 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 rho, yes. Rho, rho, yes. But never rho, mo. Never rho, mo. Now with tungsten, we will pair it with any one of these, but specifically looking at aluminum. Aluminum gets rid of the L edge down here, so that's good, gets rid of the skin dose. It also removes some of the higher energy stuff up here, but it does keep, the aluminum is actually the widest spectrum here. And this broader spectrum is actually good for digital systems because you get good, the digital systems will take care of the contrast, the loss of contrast for including these higher KVs, but it gives you more flexibility to image thinner or thicker breasts. You don't have to worry about changing different filter options as much if you're using a tungsten aluminum combination, because you have these higher photons here for denser breasts. Now, you will get penalized if you have a really thin breast or a fatty breast, but that penalty is largely overcome by using the digital system that will correct for that contrast. So talking a little bit about the type of filter you use, going back in time, as we talked about this a couple of weeks ago, we talked about the half value layer, which defines the beam quality of the photons coming out of the X-ray tube. And so when you look at these various different combinations, so here's tungsten, aluminum, here, you can see you have a relatively high beam quality. Tungsten gold, tungsten rhodium, tungsten aluminum. These have higher quality, so they have better penetration through the breast without scattering, so that you get photons in and photons out and incident on the detector. So that gives you really, really good contrast. Now you go down here at the low KVs with, say, the moly-moly, you actually had a lower quality, less penetrating. And that's why moly-moly could only be used with the least dense or the fatty or the thin breasts. So you actually just had to pay attention to that. Once you get to these tungsten anodes with all the various different targets, you really don't have to think too much about the type of breast you have. And then, of course, always remember that the paddle itself, the compression paddle, adds some amount of filters. So let's talk about how these filters how we use that to optimize our output. So we're talking about a half value layer of breast tissue of about 1 to 3 centimeters. So approximately every 1 to 3 centimeters, 50% of the photons will attenuate. You go another 1 to 3 centimeters, 50% of those will attenuate. So you go 100% as it enters the breast, 50%, a quarter, et cetera, et cetera, et cetera, et cetera, an eighth, a 16th. And so by the time you go out of the breast, you have very little photons left. So if we talk a little bit hypothetical here, well, I'm sorry, we'll do a hypothetical example, but this is why we use compression, because there are a lot of benefits to compression, which we'll talk about in a second, but the biggest one is you're going to take a breast tissue, whatever thickness it is, and you're going to reduce it. So you're effectively reducing the number of half value layers there is to penetrate. So when imaging with, say, a 20 keV beam, you have roughly a half value layer of 15 millimeters, so 1.5 centimeters. The number of photons will decrease by 1/2 every 15 millimeters. Compressing the breast reduces the number of half value layers. I just said that. So here's the example. So if you have a typical 4.5 centimeter compressed breast, then 1 in 8 photons will make it through to the detector down here. If you aren't as good at compressing that, you're just not able to fully compress it. So now the breast is actually 6 centimeters thick, then only 1 in 16 photons will arrive. So you can see here how the compression paddle will actually dictate how many photons will get through, and therefore dictate the overall actually dose to the breast, because you have thicker breasts have to get more photons, so therefore it's going to be a higher skin dose, but it'll also dictate the image quality. So compression paddles decrease tissue thickness. For one, it does help reduce the dose of the patient, which we'll talk about more next week. But two, it also helps reduce scatter. The amount, if you have less breast tissue in this field in this axis, then you're going to get less scatter. So this reduces your scatter fraction. Ultimately, mammography is actually not limited by noise. It's actually one of the least noisy imaging modalities we have. And if you ever have a mammogram, you expose it and you look at it and it's very noisy, something has horribly gone wrong, because most mammograms are not noisy because we can compress it and the system will then be able to compensate and get the right amount of photons through. So if the image looks really noisy, typically one of two things have happened. One, the compression paddle has failed to get you the right compression force or pressure. Or two, if it's contact breast, you may have actually taken out the grid and not put it back in. And so the system has not given you enough photons. All right, so let's move on to breast compression since we're here. Breast compression has many benefits to optimize image quality. One, it reduces motion. Literally, it's holding the woman in place. Two, it lessens the geometric blur. So I'll talk about that in a minute. The closer an object is to the detector, the less blur you have on the edge of an object. So less blur in the image. It reduces the overlapping anatomy. So if you have dense breasts or lots of glandular material, if you're spreading it out, and so you're spreading it out laterally, you're just going to have less material that you have to read through. And then, of course, it makes it more uniform. And so when you actually compress the breast, you have a more uniform field of view to look at instead of a very dense part, maybe at the dead center, because it's not compressed completely. This will lessen the dynamic range, so it's really good for post-processing. It's good on the computers, but it also will help the radiologist get the symmetry they need. I mean, when you do a two view, you got the craniocaudal left, right. If one's not compressed the same, you're going to get that asymmetry in the actual look of the breast, and the same with the MLO look. So when you look at asymmetry issues, so you actually have two breasts showed side by side, only about 3% of the time that the asymmetry you see is pathologic. Is based on pathology, is based on disease. In other words, most of the time you see asymmetry, it's actually due to compression failure. So optimizing the compression paddle helps us make sure we get good image quality. So here's an example. This is asymmetry due to disease, looking left to right, and the CC, and then the MLO. This is asymmetry due to compression. here, left to right here. All right. More and more frequently, we're dealing with women with implants. So we have to do our absolute best to get the implant out of the field of view. Now, I know you can't always just budge it out of the way or push out of the way like you're seeing here. In a perfect world, we would just retract the implant and image the breast tissue. Can't do that. Why are implants not good? Well, why are they detrimental? How are they not good for image quality? So when you image the implant, obviously it's going to change the dynamic range of the grayscale. Obviously, this is a fluid filled, silicone, whatever. But the point here is it's going to attenuate a lot of photons. And so this is very white. And it's going to change that dynamic range so there's less grayscale here in the breast. So in this case, where the same patient, one, they got the, in one here, they imaged with the implant in place, and the other one, they were able to largely get the implant out of the view. And you can see here how the glandular and fatty contrast is much greater in this view than this one. So optimizing the actual placement of the implant is good, and optimizing the compression. Obviously, you'll get better compression if the implant is just out of the way. Implants, of course, are less compressible. All right, we need to talk a little bit about this compression. So compression force. This is the standard by which we measure how the paddle will compress the breast. Typically, we're aiming for about 111 to 200 newtons, or as it's often shown on the scanner, 11 to 20 decanewtons. If you're here in the US or over in England, it's going to say something like 25 to 44 pounds. We know that and so what you're aiming for, depending on how you've been trained, is you're just basically going to put the breast in there and you're aiming to get a force somewhere in this range. We obviously know we don't need as much for breast tomosynthesis, and we definitely, it's a little bit different when we do the magnification or spot film compression. So more recent research in this area has looked at, I told you, the variability. If you look at image quality, it's my opinion and others in our field that most of the variability for the image quality is coming due to inconsistency of compression. And that's because we've only used one metric, which is force. So we're talking about, the decanewtons. But what if we talk about pressure instead? So pressure is force per area. So now it takes into account how much of the breast it's compressing, how much of it's pressing onto the breast. So the use of force is inconsistent across practices of mammography. Using pressure considers the area of the breast where the force is applied, which also takes into account the breast shape, the elasticity or compressibility of the breast, and overall its breast density. So we know smaller, younger breasts tend to be more dense, and then, of course, older, fattier breasts. So in this publication that came out a couple of years ago, it's about 5 years old, it's a really interesting publication. What they basically did is they looked at, it was a retrospective study, they looked at almost 40,000 breast images. And what they did is they went in and they looked at the DICOM metadata, and they looked at the compression force and the compression pressure of all of these, and then they simply did a scatter plot to look at basically what is the force as a function of contact area, or what is the pressure as a function of contact area. So here's the DICOM tags. I simply did a screen capture for you. So if you ever pull up your mammogram and you're looking at it on a PAC system or whatever reader you're looking at, if you look at the DICOM data for that image, if you go to tag 0018, 11A2 or A3, the system, if it maps it, will tell you what the compression force is and the compression pressure. So you could technically do this exact same thing. You could look at what the distribution is in your institution or for everyone in Thailand. And this study was comparing the Netherlands versus the US. And what you see here largely, what you largely see here is as force goes down, So using less force, it's actually because it also correlates with a smaller area of the breast being compressed. And what the biggest problem with all of this is, and so the way we've been doing it when we look at the use of force as a metric, well, what that means is when you see the pressure, it's actually going super, super high for these really small breasts. And so this is where you're probably getting a lot of pain up in this region. But over here, you're getting a lot less compression. And so you might actually have a lot more, you have poorer image quality down here on this spectrum. So the results of this publication, they looked at the average force was 14 decanewtons. So between 11 and 20, so that's great, right? In the Netherlands, it was actually 7 decanewtons in the US. And so here in the US, we were not compressing nearly as much. The average pressure was 14 kilopascals, and in the US, it was 8 kilopascals. So the trend was lower force to smaller contact area, which I mentioned. And the force is adjusted based on the mammographer's sensitivity to patient's pain, not to the breast size or elasticity. And so you can see here in the US, they're not using as high a force, largely because as the authors surmised in their publication, was you have a woman come in, they go down, they start to compress, maybe the woman starts to verbally say it hurts or wince, so their face just has that kind of a look of pain. And so the mammographer doesn't compress any farther. Whereas I guess in in Europe, they just they keep going no matter what pain tolerance the woman has. And so why is this an issue? And what are they proposing? And where are we kind of starting to look to change this idea? If you go in and you try to maintain a constant pressure, which you'll see here in this purple band or red band here, what that means is you have a target in your mind as a mammographer. You got the woman, irrespective of the breast size, thickness, elasticity, etc. You got her on, and you're starting to compress. You're trying to get, let's say, 14 decanewtons. And if you do that, well, for the little breasts, so contact area, you got small breasts over here, same pressure, same force, smaller area, you're going to have low pressure. But as you hold that force the same, as the contact area gets bigger and bigger and bigger and bigger, pressure is just going to go through the roof. And it's going to equate to a lot of pain. So it results in high pressure for small contact area. Okay, no, I said that backwards. My apology. I said that backwards. The pressure will change linearly. So as the force, if you hold the force the same for a small area, my apologies, the pressure goes really, really, really high. And that's where you get a lot of pain in the patients. And then as the force is held constant, what happens is the pressure goes down. And so you get less compression over here and potentially more image quality issues. So what they're suggesting is instead of a constant red line here, constant force, they're saying change the force as a function of breast size so that the pressure will be constant across all breast contact areas. So for small breasts, same pressure as large breasts. But what you have to do is you have to change the amount of force being applied to get that. So that's just going forward. What you really need to do is kind of look at how you calibrate your force. You need your force sensor so you can calibrate the compression paddle, and standardizing as best you can the way you actually apply that compression so that you get equal compression, so more uniform imaging across all breast sizes. All right, just briefly talking about the anti-scatter grids, we know, so we're just moving down the chain here. The grids are very important because they reduce the amount of scatter. So photons come in, they interact in the breast, they cause scatter. We use the grids to clean that up. Decreasing the amount of scatter increases or improves signal to noise ratio. Using grids, we only use them in contact mammography only. We do not use them in magnification mode, and they allow roughly 60 to 70% of the primary photons to go through the breast and through the grid to the detector, but they're really efficient at absorbing 75 to 85% of all the scattered radiation. So in contact mode, you should always, always, always image with a grid in. Now, when we do magnification mode, now what we've done is we've placed a little magnification platform on. The breast is a little higher with respect to the tube to the detector. This gives us the ability to image so it projects the anatomy larger on the field of view. So we get just a magnified view of the breast. You can see the typical magnification modes are 1.5, 1.8, or typically 2. So if you get that breast somewhere in the between, source to object distance of about 35 centimeters versus the object source to detector distance, which is usually fixed at 65, so basically right in half, that's where you get a magnification of 2. Kind of makes sense. We went over this equation before. I simply give it to you again. So the benefits of magnification, of course, is it really takes a small object and it allows you to see it a little crisper and a little cleaner. Remember, in magnification mode, the limits of your resolution is this detector itself, not the focal spot. So you can now start to see 0.1, 0.15 millimeter objects, which is what we said was a mandatory requirement in mammography. All right. When you image in magnification mode, there's actually less noise, apparent noise in the image, because you have the same anatomy being shown bigger on the matrix or your detector. And so it didn't, when you just look at the ratio of anatomy to noise, it's just larger. So these images will inherently look less noisy. And like I said, this is one of the reasons why mammography is actually a relatively low noise uh, modality. Now, we take the grid out because we don't need a grid because now there's space. We have this air gap right here. So photons come in, they interact with this breast, they're going to scatter. And a lot of those scattered x-rays will just scatter into the room. They will not in any way interact with the detector. And so remember when we talked in fluoroscopy and even in, well, mostly in fluoroscopy, if you do geometric magnification, it increases the amount of photons. The system, it increases the dose of the patient because the patient is literally closer to the x-ray tube. But if we take the grid out, we don't have to use as many MAs, we don't have to use as many photons to image the same thickness of breast. So the air gap reduces a scatter, and by removing the grid, it also reduces the amount of MA that we need, which also reduces the amount of scatter. So it kind of balances the scatter and noise in the image, and it reduces and balances the dose of the detector. So it's equivalent, but we'll talk dose next week. So what are the limitations of magnification? Well, we talked about this, of course, a while ago, but the closer an object is to the detector, the sharper or crisper the edges are. The farther away from the detector, because our focal spots are finite, they're not infinitely small, they're actually finite, we will get some of this geometric blurring, which causes the edges of our objects to be a little bit less sharp, less crisp. So that is an issue. You're going to get a little less sharp, a little less crisp objects. That says you'll be able to see much smaller objects, so it kind of somewhat balances itself a little bit. Obviously, motion's an issue because if you're higher up and you're imaging for upwards of 3 seconds, there's greater chance for movement. Okay, so so that was all 2D or full field digital mammography. So digital breast tomosynthesis, or DBT, enhances the contrast in the image because now we're going to acquire a three-dimensional, quote unquote, three-dimensional view of the breast by sweeping the tube over the breast and acquiring a series somewhere, around 15 or so images. And then that'll allow us to create a stack of images. When they've done various different studies, and they've been looking at this for now almost 20 years, the sensitivity and specificity of the radiologists as they read mammograms increases in tomosynthesis or 3D imaging compared to the 2D full field digital mammography. Why is that? Well, I don't have to be a radiologist to tell you that there is something here as you take an image and as you image it across the sweep, you're then able to then reconstruct, basically kind of cut the image, the breast, in like a loaf of bread. So in a craniocaudal, it kind of cuts it, obviously craniocaudal and medial lateral the same way. So you have the stack. And so often, as radiologists do, they'll be looking at it in 2D mode. If they think they see something, they'll flip over to 3D mode and verify that it's there. Now, the beautiful thing about 3D mode is you actually have all the information for 2D. It's all there. We just have to reconstruct it. And so more and more common now are the synthetic two-dimensional view image. And each mammography vendor will call them different, like C-views or synth mammos. They're all different names, so don't get caught up on that. But all it is just taking the stack of images and projecting them into a two-dimensional image. Now, you cannot take a craniocaudal tomosynthesis and project that into a medial lateral. So in CT, you can acquire the image axially, and then you can create your reform at sagittal and coronal and axial and all that. But in tomo, if you want a synthetic MLO, you have to do a tomo sweep in the MLO. And the same thing for the craniocaudal. If you want a synthetic of the CC, it's got to be in that. So that is one thing to consider. The benefits of the synthetic is that it's been shown to be equally sensitive and have equal sensitivity and specificity as a traditional, true, acquired two-dimensional full-field digital mammography. Allows side-to-side breast comparison, whereof, of course, you can't really put these side by side. It's a stack. But traditionally, obviously, you do your CCs and your MLOs side by side. So that still gives you that a traditional way to view the breast. Gives you the ability to look and assess interval changes, visualize microcalcs. Microcalcs are not as well visualized in the tomosynthesis sweep because there is blurring that occurs. Blurring because A, the breast is hold still, but the tube is constantly moving when you're acquiring imaging. It's not image, stop, move, image, stop, move. It's not stop, step, and shoot. It's actually a constant movement. So there is going to be inherent blur. And two, the way they reconstruct it is they blur everything out of the plane of view. And so if you're trying to look at a specific view in the breast, so like let's say mid-breast, everything outside of that, above and below, it's going to be still projected into this 2D image, but it's just out of focus. Microcalcs are so small that depending on how you reconstruct it, you just may completely miss it. So typically when we're looking at these microcalcs, they're best to be seen in 2D, either in the synth mode or of course the actual 2D FFDM. And then probably one of the best things about this is these synthetic 2D images are free. You acquire the tomo sweep, you can reconstruct into 2 dimensions. You don't actually have to acquire two series of imaging. What are some of the the things that you have to be aware of when it comes to image quality in a 2D synth image? First of all is you're going to have artifacts. And here I'm going to show you a series of images on the left, which are the true two-dimensional full-field digital mammography, and then the others are the synthetic. Whenever you look at a synthetic, you're going to get these out of plane or what they're called slinky artifacts. And so you have a really high contrast, high attenuate object that spans multiple slices of the tomo series. Well, when you combine them all, what happens is you actually lose some of that information out of plane. So obviously this black area, that is an artifact. That is not true anatomy. But that is if I didn't tell you this is a synthetic image and you saw a high contrast object with these big telltale black stripes on both sides, you would know it's synthetic in a heartbeat. And these are going to show up where there's surgical clips, biopsy markers, dense calcification, etc. All right. Synth modes will at times not have really good, clean skin lines, and this has a lot to do with the fact, especially if you have a dense breast and you're doing a tomo sweep, you're going to have a relatively high MA, and it tends to burn out the anatomy when you do the reconstruction. Not physically burn it out, but when you reconstruct the image, because you have saturated the detector right here with high levels of photons, it tends to blur, it removes that information. Whereas in a 2D view, you don't need as much MA, so it doesn't over time, so it doesn't actually cause you the degradation of the skin line. You'll also get these bandings in the synthetic, and that's just because you're taking a three-dimensional object and you're averaging it together in multiple planes of view. So I would be remiss if I didn't say something about the viewing station. You've gone to all the trouble to get the right KV, the right filter, the right compression. You're optimizing your contrast, doing full field digital mammography or tomosynthesis, and then you try to read this on a horrible monitor that's out of calibration. You're doing yourself no service. So once you have done your best to optimize the machine and the output and the reconstruction, you've got to absolutely have a good monitor, especially in mammography. In mammography, you have to have a high megapixel system, at least greater than 5, so that you can see the resolution that we're demanding for these microcalcs, etc. So you need to have at least a matrix size that's about 2000 or so and 2500 by 2500. The pixel depth is the same. You can remember our eyes can only see so many grayscales. So 256 and 8-bit is fine. You want a physically large monitor. Everything we image with mammography is actually in mag mode, because the image itself, the detector itself, will produce an image that is larger than 2000 by 2500 pixels. So when it's presented in 1-to-1 ratio, the breast is big. And so the bigger the monitor, the more of the anatomy you can see at one time. Inevitably, when we're actually looking at the full breast anatomy in the image, especially if you have multiple views, CC and MLO next to each other and multiple time points, you're actually looking at a highly zoomed in, demagnified image. And so you want to be able to see all of these standard images like this. And that's actually an important thing. I want to just remind you this. We talked about this a while ago, but how can you optimize the contrast in a viewing situation? Obviously you need to have your lights right, but the closer you are to your monitor, the less your eye can see the contrast. And that's just because of the geometry of your retina. The closer you get, the more photons are, the smaller the area of the smaller your viewing area is. So you're only able to fixate a certain amount of photons or light coming out of the monitor from a small part of your monitor into your retina. But the farther back you go, the more pixel light coming out of your monitor will strike your retina itself. In other words, you can visualize more subtle low contrast the farther back you are. Now, I'm not advocating everyone stand 20 feet back when they're reading a mammogram. What I'm saying is when you look at a demagnified image, subtle low contrast findings will pop a little bit more to your eye. And, I don't know how every radiologist does it, but a lot of times if you pull up and you have like your MLO and your CC for one time point and maybe your MLO and your CC at the baseline, so you have basically so you have obviously 8 breaths and 4 2 time points and 4 views up. It's very small by way of detail, but the subtle changes and maybe architectural distortions or asymmetry will appear more to your eye. And so then you can do that as a quick survey. And then you kind of know, okay, maybe this is a region I'm going to focus on. So when you pull up the straight MLO or you look at just that breast itself, you can then interrogate that area more clearly. So the point here is image quality is great. Low contrast is important, but we can actually optimize image quality just on the way we look at our images. You need to standardize the Mammo image quality. So I give you the example here in the US. We have a standard. It's called the MQSA. And it defines a minimum image quality that every system has to perform at. Every breast image acquired in every view, CCMLO, whatever, tomosynthesis sweep, has to meet a minimum standard. And we've been doing this basically since 1992. I don't know, admittedly, I don't know what the rules and laws are in Thailand. I assume you have something like this. I would hope that you have a general consistent standard, because this really helps make sure from view to view, time point to time point, especially in a screening modality, you're getting consistent image quality over time. And no matter where the individual goes, whatever hospital. Our MQSA actually goes beyond just saying image quality, setting image quality standards. It sets competencies. So radiologists, technologists, physicists, we have to meet a specific competency so that we can operate in the mammography space. And it, of course, sets minimum image quality, and it tells us how high the dose can be. And it should be no higher. Obviously, that's very important for screening mammography, which we'll talk about next week. So just in closing, we talked about how there are two competing image quality metrics we have to optimize in mammography: spatial resolution and CNR, and how they're competing. They're antagonistic. Spatial resolution wants high dose, wants low MA, so you can have a small focal spot, and high KV for good penetration. And that in itself will be bad for CNR. In CNR, we want low KV and relatively high MA, so we get good contrast, low noise. And we talked about how we can overcome that by using small focal spots, doing either contact or magnification, getting the right anode, mostly nowadays the right filter combination, and etc. So, yeah, that's what I just said. And that we need to develop a constant approach to compression. And that I hope I shared enough insight to think that the compression is really a good way for us to keep the breast looking consistent from time to time, getting the anatomy all spread out and whatnot. And then, as I mentioned, we should standardize, if you have not already, come up with a standard national image quality standard so that every mammogram ever acquired in Thailand will meet a basic minimum so that we know the image quality is consistent for all of our patients. All right, thank you.
Thank you so much, Sam. So I think in Thailand, we use the same approach compared to US, including a BIRATs and also like an image quality for the to test the machine, and also like we have like a dedicated mammo technologist.
Okay.
To do that part, and also physics. But I'm not sure about radiologists, because I know in US you need to read a certain amount of number to be certified every year. But in Thailand, I'm not sure on that part. But most of the people who doing mammogram usually just like a focus on mammogram.
Yeah.
So because like this is like a very, I think it's like a very detail-oriented study that you to train your eyes to see something like a very, very small stuff. For me, if you ask me right now to read mammogram, I'm not sure that I can do that to call microcalcifications. See that really well. Yeah.
Yeah. No, it's very highly specialized, and so yeah, I completely agree with that.
So, and I remember on like the first couple slides in your talk, you talk about like a molybdenum and rhodium, right? RH, right? And those I remember those things from the old days when I was a resident for that we need to take the exam on those things and also have value layer. But right now, I don't, I'm not sure that I remember those things. Yeah.
Yeah. So most of that, I mean, unless you're using a GE scanner, you don't have to worry about Molly and Row anymore. Every scanner, the Siemens, the Philips, the Sectra, all of those, Hologic, they're all using tungsten now. And that's because, and I assume this is probably the same for Thailand, most institutions are moving towards tomos. Almost all systems are tomo capable.
Yes.
Now, does that mean everyone gets a tomo? Maybe not, but a lot of the time now, especially for baseline imaging, you're going to get a tomo and you're going to get your 4 views to, CCMLO for both breasts. And that becomes your standard. If you're low risk, then it might just be full field digital mammography going forward. But the point is having that ability to do all of that imaging, you need a tungsten scanner, a tungsten target. And when it comes to half value layer and making sure you set that all up right, if you've set the right KV, the system will get you the right beam quality. But
Mhm.
if you don't get the right beam quality, then obviously the penetration is off, and so you will have a problem, and it's almost always manifest because you are limited with how many what how much MA you can use. So almost always, if you don't have the right beam quality, you don't have the right compression, if you don't have the right KV, if you don't have all of that, it's time. The only thing it can do is leave the system on longer, and that induces more motion blur.
Mm.
And so usually if you see consistent motion blur in your mammograms, that's where you need to start going back. Okay, am I compressing properly? Do I
Mhm.
have the right KV? Do I have all those other things? So the type of artifacts you see in mammogram will actually help you kind of troubleshoot what's going on in the image.
Mhm. I see. Yeah. So come to the questions about the standard compression force. Should
Mhm.
it be like a 25 to 40 pounds? How is the practical force in USA?
Yeah, so that's what they aim for in the US.
Mm-hmm.
And but what we're seeing more now is they're moving kind of away from this idea. That's this right here. So if you look at the red right here, and I screwed up when I made the mistake when I was explaining this, so I'm sorry. It's probably very confusing. If you have a consistent force, say 25 or 40,
Mm-hmm.
then what's going to happen is for your really little breasts where you have small area of pressure, but you're still pushing as hard, you can see here the curve goes really, really high. This pressure goes really high, and that's gonna hurt.
Mm-hmm.
Whereas if it's on this side and you're still using the exact same 25 decade or pounds or whatever it is that you're using force wise, but it's a larger area because it's a larger breast, then it causes problems down here where you're not compressing it enough. And so the whole concept here is to move towards this idea of now the system will take into account the actual area of the pressure, the area of the breast, and the density of the breast, and it will apply different force for different people. And that's where you get different forces will give you the same pressure. In other words, the same compression. This is a work in progress. The systems are getting better at being able to do this, where it can make a general guess or estimate based on the area as it's pressing down and the overall glandularity or the elasticity of the breast.
Mm-hmm.
And that would then help. There's an algorithm in the system that would then be able to decide which force to use. Now most mammogram systems or mammography units, the force is applied with the foot pedal. You know, the mammographer gets the patient in, gets the breast situated, and they're starting to apply the pressure as they're moving their hand out. Just a typical situation, and they're pressing down based on obviously the number, but also based on what the patient is experiencing. And so the hope is that we can start to use more intelligent the computer can the system can be more intelligent and it can help them say aim for this force, and that would be a way to help give them a target based on the patient's size and density. So like I said, it's kind of more of a work in progress, but I honestly see in the future this is where we're going to be, where it's going to be more, instead of us thinking as much about density, excuse me, force, it's going to be pressure, and it's going to be more consistent across different patient sizes.
You mean like an AI technique or something that integrate to the system that can adjust the force or like a compression
um
stuff?
The answer is yes, that could be a part of it. Admittedly, this is a little bit early on in the implementation. A lot of the systems have a way of calculating. Um, you can you can tell the system, you know, general density and size. The mammographers know all of these when they're
Mm-hmm.
kind of setting the patient up and going forward. And so basically by telling the system these things, the system would know, oh, okay, well, if it's a smaller breast, potentially more dense, then it would know to give a different target force. So as they then step on the pedal and the compression pedal comes down, it would then help give them feedback as to, okay, now you've got the right force instead of going all the way down to you have 25 or even 40
Mm-hmm.
pounds.
I see. I see. So that clear a lot of stuff. Yeah.
Yeah. And so, I mean, admittedly, the guidelines are loose right now.
Mm-hmm.
And it's the same way here in the US and Europe as I assume it is in Thailand, is each mammographer is going to set the pressure based on how they've always done it, how they've been trained.
I
But
think so.
that's consistent from person to person to person to person. And
Mm-hmm.
like I said, the compression really, really changes the image quality in the image. And so if you're not consistent, especially from patient to patient, so you go from time one to second time or third or fourth time, if the compression's not right, you're asking the radiologist to have to look at the anatomy differently every time.
Mm-hmm.
And that's the
Mm-hmm.
idea of trying to be more consistent with the compression because it makes the image quality more consistent over time.
I see. Yeah, that makes sense. So the key is compression. We need to get the right amount of compression to get a good image quality and consistent quality. Mhm.
Yeah.
Yep. Okay. So let me see. Seem like we don't have any questions right now. Yep.
Okay.
Yes. So maybe next week that we are going to talk about the dose and also how to set up the dose alert level that may more like a more practical for us and we can like concentrate on that part of for the dose
Yeah.
things. Mhm.
Yeah. We're definitely going to talk about the dose metrics. Well, actually, there's only one mean glandular dose. We'll talk about that. And then we'll talk about how to optimize that. And
Yes.
so, yeah. And just like we talked about at the beginning, if people in the audience have specific topics or questions they have, we have two
Yeah.
more weeks.
We have two more
So,
weeks.
yeah, we can focus part of next week on a topic.
Uh-huh.
Or if you let me know soon, if
Yeah. So
not, we can,
yeah. Mhm.
or if not, we can definitely focus on maybe two specific topics in 2 weeks
Yes.
from now. So, however you all
Yes.
want to do that.
So for the audience, if you have any like a specific questions or topic that you want Dr. Blatty to talk about, so send me an email or you can put on the Facebook on the link on the live that we have right now, so I can communicate with Sam so we can get that topic delivery to you in next 2 weeks before we finish this course. So I think we are done for today. So please complete the evaluation form by Thursday midnight. So Friday you will get a certification and also a link for next week, which we're gonna talk about the dose for the mammogram and also how to set up the dose alert level. And yeah, I think that's it. So thank you so much, Sam, for giving us a talk today. And I will see you again next week. So have a good night and thank you so much, everyone, for attending the lectures. สวัสดีค่ะสวัสดีค่ะบ๊ายบาย